All right, can you see that? Hello?
Yeah, I can see it. Yeah.
So I'll be presenting a case that I saw in clinic. I'll start with some history and background, then view some investigations and imaging that were done, how we managed and followed up, and then we'll close with some conclusions and take-home messages. So this was a 2-year-old boy who at the age of 9 months started to manifest with various symptoms that included recurrent blanching non-urticarial red rashes. He also had recurrent vomiting with no obvious pattern or trigger, sometimes vomiting during the meal, immediately after, or hours to a day after last meal. Vomiting episodes occasionally preceded by feeling of dysphagia or unusual, as the family described, sounds of throat clearing. And they also reported specific foods being stuck. So, for example, when he has chips, he immediately after start to produce these sounds, start to gag, cough, and vomit. He had a normal bowel motion. He also had recurrent cough, shortness of breath, wheezy chest episodes with 3 previous hospitalizations with respiratory tract infections. However, his respiratory symptoms did not seem to be persistently linked to specific food triggers. So, given the overall picture, what do you think? Please leave your answers in the chat box. So do you think, A, this is a food-triggered allergic reaction, or do you think this is reflux, esophagitis, unlucky with recurrent viral illnesses, or do you have something else in your mind? Was managed by his GP as a case of reflux. He was commenced on Gaviscon and lansoprazole with no obvious benefit. Months after that, family sought advice of a private doctor who thought of food allergy as a possible differential diagnosis. So a very full, sophisticated allergy panel that included more than 50 foods and environmental allergens was done. He was given advice on multiple food avoidances. And he started to already avoid these foods based on specific positive IgE levels. So after months of struggle, he presented to us with a very long list of food avoidance. So he'd avoided tree nuts, peanut, lentils, fish, beans, peas, egg, tomatoes, potatoes, chickpeas, sesame, dairy, and wheat. He'd already started to show signs of food aversion and started to develop picky eating habits. He was also still coughing, vomiting, feeling very unsettled after meals. So we had to take a very long, detailed individual food history, which was suggestive of food-triggered reactions to only peas, eggs, tomatoes, and hummus. However, we could not tell whether it was the chickpeas or sesame and hummus because he'd never tried them individually. So on examination, he was noted to be thriving really well. So his weight was hitting the 88th centile. His height was on the 5th centile. Strikingly, was found to have diffuse, loud, biphasic, bilateral wheezes with no other signs of respiratory distress. He was also noted to have eczema patches. All right, so now what differentials do you have in mind for someone with persistent vomiting? And what investigations at this point would you like to do? Would you like to do A, chest imaging, or B, barium studies, further allergy testing maybe, or food challenges, or an upper endoscopy, spirometry, or all of the above? If you have any comment or answer, please leave it in the chat box.
So we've got A and D
Mm-hmm.
from one, F from another.
Good.
So they're the two we've got so far.
All right, so because of how impressive his chest auscultation was and the fact that we did not have any baseline chest x-ray to compare with, we had to do a chest x-ray to start with. Interestingly, his chest X-ray was very abnormal. So as you can see, there were right upper fluffy consolidations, right middle lobe collapse consolidation, both right and left lower lobes consolidations, with no pleural effusion, and heart seemed normal. At this point, we still thought of his bizarre symptoms of his GI, basically symptoms of dysphagia, vomiting, these weird sounds that he were producing after meals. So we had to also rule out any possible structural or dynamic anomalies in his upper GI tract. So we've done barium swallow and follow through. And you can see barium passes normally into his stomach with no significant gastroesophageal reflux noticed. And there was no malrotation or any other anomalies. All right. So at this point, our initial impression was that this is basically asthma. So we had to treat with Clinil 100 mics, 2 puffs BID, with a plan to repeat his X-ray in a few weeks. For his GI symptoms, we thought that his vomiting mainly is attributed to cough, so post-tussive vomiting, and this should settle with the treatment of his asthma, but we still needed to rule out eosinophilic esophagitis as a main cause for his dysphagia. Allergy-wise, we started to put on a plan moving forward to reintroduce all the foods that he was unnecessarily avoiding. And we kept in the horizon his behavior problem, like his picky eating habits and food aversion. So we started to create a kind of holistic approach that involved nutritional and dietetic help and support that we felt he needs. Further to that, we brought him to our joint immunology gastroenterology clinic, as I say, to discuss whether we need to scope him, take biopsies to rule out eosinophilic esophagitis. We started with a repeat X-ray, and as you can see, there's a significant improvement in his chest X-ray, previous chest X-ray findings. So the lower the right middle zone, the left and right lower zone consolidations have totally resolved. The family reported massive improvement in his chest symptoms. They reported that his vomiting completely subsided. They successfully at this point introduced dairy, wheat, and fish. He was no longer having problems with food seemingly getting stuck on swallowing, like he had trips, and he was fine with that. His bowels were still regular and normal, and he was described by his family as a totally different, happy kid. So at this point, upper endoscopy plan was held because of the obvious significant improvement. And we made a plan moving forward also to introduce other foods like nuts, tomatoes, lentils, and later to introduce the egg ladder. So he only at this point needed to totally avoid peas and hummus. So this is splendid news, but this got me really wonder why managing his asthma was really impactful on his overall well-being and his GI symptoms. I feel that was really interesting. So I've done some exploration, and I've come across a few very interesting articles. Just please don't panic. This seems like a very busy slide. I will try to simplify things. So there are many studies that describe the strong correlation between people who had obstructive airway disease like asthma and how it impacted or affected their swallowing dynamics. So it was found that there is a very strong association between uncontrolled and severe asthma and the appearance of changes in the stomatognathic system. So what is the stomatognathic system? It's kind of a functional complex of tissues and organs involved in functions like speaking, chewing, tasting, and swallowing. So this was very well established in adults. There's a little data about pediatric age group, but this is very well established in adults who had severe obstructive airway disorders like asthma. So there's a very nice, like kind of a cycle, which is the swallowing breathing cycle, which is really, they are really connected to each other, and they have to function in coordinates for you to have a normal swallowing and breathing pattern. A very fascinating medical term that I've found, which is commonly used in respiratory and adult gastroenterology, which is called respiratory dysphagia. So basically, this is dysphagia described in patients with respiratory obstructive disease like asthma. So people who have respiratory dysphagia might present to you with reduced appetite, difficulty chewing and avoiding certain textures, which our patient had, becoming increasingly short of breath whilst chewing, taking longer to complete a meal, sometimes wet, gurgly voices during or after swallowing. Also, our patient had this. They might also present with increased shortness of breath after swallowing, sometimes sensation of food sticking in throat, which also what our patient had, coughing during or just after eating and drinking. He also had this, feeling full despite only having a small amount of food, getting tired after eating and drinking, experiencing more acid reflux and indigestion, difficulty taking tablets, and chestiness or recurrent chest infections. Interestingly, our patient also had this. So as a summary, this is a 2-year-old boy who presented to our clinic with a long-standing history of respiratory symptoms, included cough and previous respiratory tract infections. He also had vomiting and dysphagia. Vomiting mostly was post-tussive. He presented with a long list of food avoidance, mostly relying on positive IgE levels, with a minority due to persistent allergy symptoms with a correlation to his symptoms. He was showing picky eating habits with early signs of food aversion, which was of a huge impact on his life and the whole family's life. So my take-home messages from today is that we, as much as we are trying sometimes to help, we might confuse things. So allergy testing in the absence of persistent food trigger is inappropriate and shouldn't be done. Also, we have to think of common symptoms of eosinophilic esophagitis that might be dismissed, like anxiety, food aversion. Picky eating habit is a very common one. Dysphagia, reflux type symptoms. So always think of eosinophilic esophagitis. Also, we know that eosinophilic esophagitis symptoms and symptoms of food allergy can tremendously overlap, and sometimes it's very difficult to delineate those. Always do a thorough physical examination. It's really useful to exclude any confounding factors that will affect your overall judgment and treatment and the outcome. Interestingly, as I just mentioned, airflow obstruction might interfere with swallowing, increasing the risk of dysphagia, reflux, and aspiration. Thank you very much.
Okay, many thanks, Walla, for an excellent presentation.